Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we're going to be talking about portal vein pathologies. Normally, the portal vein has a smooth, gently wavy flow pattern. We call that phasic. But if the flow starts looking pulsatile, like arterial, that's a red flag. When we see this, it often points to heart-related issues like tricuspid regurgitation or right heart failure. Portal vein thrombosis can be either bland or tumor related. Bland means it's just a clot, maybe from hepatitis, pancreatitis, or a clotting disorder. In babies, dehydration or an infection around the belly button, that's omphalitis, can also be a trigger for this bland tumor. Tumor thrombus, on the other hand, is when cancer, most commonly hepatocellular carcinoma, invades the portal vein or invades the vein. We call it tumor in vein. That's a tumor thrombus. On ultrasound, you will see no blood flow in the vein and possibly a solid looking clot, that's something echogenic within the vein. If the clot lights up with color Doppler, it's likely a tumor thrombus. So this grayscale transverse image of the porta hepatis shows echogenic debris within the main portal vein, that's pointed to by these arrows, and this color Doppler confirms partial portal vein thrombosis with lack of flow in the proximal portal vein, seen by this arrow. You can see that there's some blood flow here, but then no blood flow, pointed to by this arrow. Also, keep in mind that really slow flow, that's when we have flow less than 16 centimeters per second, especially in people with portal hypertension, can look like a clot, but it isn't. So let's be cautious. If the clot's been around for a while, the body tries to work around it, and so it creates a tangle of tiny new veins. That's like some collateralization. That's called cavernous transformation. So we have a cavernous transformation around the area of the porta hepatis. So these images show us cavernous transformation of the portal vein, and this grayscale transverse image of the porta hepatis shows numerous tubular hypoechoic structures in the expected location of the portal vein, that's pointed to by these arrows. And the Doppler in this right image demonstrates flow within these collateral vessels with no identifiable single portal vein. So we realize that the portal vein has been transformed into this cavernous formation. If you see gas in the portal vein, think bowel ischemia or infarction until proven otherwise. It's a medical emergency, and CT is the next step if you are really not sure what the cause of this gas in the portal venous system is. On ultrasound, it looks like little bright bubbles that may move, and Doppler would show these intense spiky signals. Also, it's important not to confuse this phenomenon of portal venous gas with what we call pneumobilia, that's air in the bile ducts. And this tends to appear more centrally, and it makes sense because bile would move towards the porta hepatis while blood would move from the porta hepatis towards the periphery of the liver. And so gas in the portal venous system would be moving towards the periphery, so we'd see it more in the periphery, and then gas in the bile ducts would move towards the porta hepatis, and so we would see it more centrally. Portal hypertension is just high pressure in the portal system. It can happen for different reasons depending on where the blockage or the problem is. So it could be pre-sinusoidal, for example in thrombosis, and it could be sinusoidal, and the most classic sinusoidal cause is cirrhosis. And it could also be post-sinusoidal, and the classic post-sinusoidal cause is things like bad Chiari or inferior vena cava thrombosis, that's post-sinusoidal. You technically have portal hypertension if the portal vein pressure is over 5 millimeters of mercury, though honestly we really rarely measure it directly. When the pressure gets too high, it can slow the blood flow within the portal vein to even below 16 centimeters per second, or it could even cause it to move in the reverse direction, and that reversed flow is called hepatofugal flow. Think flea in the liver, hepatofugal. Other signs we look for include enlarged portal vein, The normal size tops out at 13 millimeters during quiet breathing. So if you start seeing the portal vein appearing larger than 13 millimeters, you start thinking possible portal hypertension. Splenomegaly is also one of the signs. Gamma-Gandhi bodies that are tiny iron-laden nodules in the spleen also point to some portal hypertension. Also, when you have varices, that's swollen veins, you should be thinking portal hypertension. And also portal systemic shunts, that's abnormal bypasses between the portal and systemic systems, most often around the esophagus, that's esophageal varices, some around the umbilicus, some around the kidneys. Now here's a pro tip: not every portal systemic shunt is equal to portal hypertension. For example, if you have an isolated splenic vein blockage, just the splenic vein being blocked from maybe pancreatitis, you might get some shunting occurring, but that's not necessarily from a problem in the liver. It's not from portal hypertension. The portal vein has not even formed at that point. But if you see a reopened or a recanalized para-umbilical vein, that one is diagnostic for portal hypertension. So this image shows us splenomegaly and splenic varices. It's a sagittal ultrasound of the left upper quadrant, and it shows an enlarged spleen, and there are also numerous tubular hypoechoic structures at the splenic hilum representing varices. If portal pressure is too high, we can create a shortcut with TIPS, that's transjugular intrahepatic portal systemic shunt. It connects a portal vein branch directly to a hepatic vein, bypassing the liver. Now, ultrasound follow-up is key. We check TIPS flow starting right after it's placed, and then at 1 month, then every 3 months for the first year, then every 6 to 12 months after that. In a working TIPS, the flow goes towards the hepatic vein. So this is hepatic vein. Flow goes towards the hepatic vein. That means that flow in the main portal vein should be hepatopetal, that's moving towards the liver, and flow in the right and left portal vein would be hepatofugal. That appears to be moving away from the liver, but in reality it's actually moving towards the TIPS. If the TIPS gets blocked, then the flow patterns will reverse again. So the right and left portal veins go back to being hepatopetal. That re-reversal is your clue that the shunt is not working anymore. To wrap it up, pulsatile flow usually means a heart issue. No flow in the portal vein could mean a clot, and internal flow in that clot means tumor. Gas in the portal vein is an emergency. And finally, portal hypertension and TIPS each have their own set of flow patterns to watch. Thank you for your attention. I hope you had value from this discussion. If you did, give it a like, share, and subscribe if you have not subscribed yet. Next, we are going to be talking about hepatic vein pathologies. I will catch you in the next one.